Thank you very much for joining everybody today. So we'll start, as we always do, with a little bit of housekeeping. So we are recording the webinar today, and your microphones and cameras have been turned off just while we go through the presentation. But if you do have any questions, or if you have any suggestions or comments as we go through, please pop them in the chat and we'll have a look at them a little bit later. If you haven't joined through the registration link, if you've had a link that was shared by somebody else, please can you just make sure that in the chat we have your email address and job title, so we can make sure that you get all of the information after today's session. So today's presenters are myself from Redmoor Health, and Rachel Edwards and Alice Benton from At Scale. And we will be joined again by Kamal Bayer, who'll be helping us with the Q&A at the end. And hopefully some of you may want to join in and give us a little bit of an update of your progress so far. So, oh, skipped there. This session is brought to you again by the D&T Network. So the Digital and Transformation Network came to life in September last year with an aim to connect everyone across healthcare interested or involved in digital and transformation. So we've grown. We've currently got over 1,200 members from primary care, and we have also added a community and voluntary category to broaden the discussions for our neighbourhoods. So we'll be sending out an invite to everybody after this session. If you're not already a member, please have a look, or you can scan that QR code that's on the screen now so that you can join the network and join in the conversations. Rachel?
Hi, thanks very much for that, and hello everyone. Thank you for joining. I just wanted to introduce you to our Practice Leaders Network, which we will be launching later this month. And for some reason, half the slide's missing. I don't know how that's happened. Oh, there it is. So this is a network, community network that we've created as a result of many of our partners and clients wanting to have a space to share and ask, and to have some downloads and thoughts around, and getting summary documents. You know when you get those 100-page documents and you're thinking, where am I going to read this? So we'll be launching this at the end of the month. I'd be delighted to see as many as you as we can. We will be extending this beyond what we call practice leaders to our community and voluntary sector, as we've worked with those, and you're so critical to making success in neighbourhoods. So there's weekly need to know summaries, briefing, discussion boards, safe and moderated spaces, a resource library of our templates and our readiness assessments, and quarterly webinars where we will very much be looking at what's happening now, but we'll also be really guided by yourselves on what you would like covered, and leadership insights and posts, and talking about how to manage that change process, and useful tips there. So we look forward to many of you joining us at the end of the month. So thank you very much, Claire.
Fabulous. So yeah, we will be sharing that information on our D&T network for At Scale's new network. So you'll be able to join from the end of the month. So the agenda, so what we're going to look at today is a summary of what's been covered so far in the other two webinars. We're going to have a little bit of a look at data sharing and digital infrastructure, and then move on to the measuring and demonstrating that neighbourhood impact and showing how we can do that. And then we're going to show you some examples of progress from attendees that have been on some of our sessions, and then explain some of the support that is available to you from us, and then we'll move into a Q&A session. So what we've covered so far. So we have covered a lot. So we've looked at components of neighbourhood services. We've looked at why strong relationships across GP practices, community teams, mental health, social care and VCFE sector are at the heart of neighbourhood working. We've talked about one clear vision for neighbourhoods agreed by all partners, and this includes choosing shared outcomes and measures so everyone is working towards the same goals. We discussed the importance of starting with a shared baseline, knowing that we are now using data, dashboards and experience, and this helps to track movement and spot gaps. We've looked at preparing for those new contracts and how you can do that. We mentioned the D&T Hub readiness assessment and how that is available for you. We've looked at how neighbourhoods fit into those contracts and the plans, such as supporting those national priorities such as prevention, early intervention and better access. We've explored the early opportunities and the areas of focus. We have looked at population health management, sharing using that and the different approaches to group patient needs and spot who might benefit from early support and design small tests of change. We looked at shared leadership structures and mapping the whole neighbourhood workforce. And we've talked about treating data as a learning tool, not as a performance report. And then lastly, today session, we're going to talk about the final one, which is making sure that partners can share information safely and consistently to understand each other's systems. Making everything, including in here, is going to be making a more joined up, proactive neighbourhood service for you. So you may remember that we shared this last time. So this is just a quick overview of when documents or frameworks or contracts are expected to come out that are around neighbourhood working. So we were expecting that model neighbourhood framework to come out in November. It's not here yet, but we'll keep an eye on that. But just for reference for you, it'll be in the pack so you can have a look through. So what should you do when you first want to get moving? So these are the simple starting steps that help build those teams and the momentum. So start with leadership by agreeing a small group of people who'll guide work and keep everyone connected. So remember, this doesn't need to be formal. It just helps to stay organised and clear. Next, set up one regular meeting where partners plan together. The aim is to make progress each time, even in small steps. Then agree short shared visions so everyone understands the direction of travel, and this gives you a clear anchor for future decisions. And then make sure we've got people involved from the start, not through big events, but through simple, regular conversations that help to test ideas early. Also create a basic map of neighbourhood workforce so you know who is available and where you have strengths and where you need to build on. And finally, getting the basics of data in place by checking what information you already have and how you can use it safely to make those better decisions. So these will help neighbourhoods begin a steady, practical way without having the need to have everything perfect first. So moving on to looking at data sharing and digital infrastructure, why do they matter? So data sharing and good digital systems are the foundation of joined up neighbourhood care. So when teams can see the same information, they can work together more easily and avoid repeating work. Shared data helps everyone understand what is really happening and makes safer, faster decisions. And when we combine numbers with real stories from patients and staff, so we start to get a clearer picture of people's needs. Strong digital tools and simple ways of sharing information build trust between partners and help services run smoothly. So together, these things support the wider goals of the integrated neighbourhood team, such as that preventing illness and acting early and working better as one team to reduce those local inequalities. So neighbourhood teams need simple, safe and consistent ways to share data. And this starts with clear data sharing agreements, DPIAs, written in plain English so everybody understands them. Now, we've had some practices reporting having up to 70 sharing agreements for different platforms and ways of working, and it's often becoming quite overwhelming and confusing for some people. But these agreements should be in place and should be reviewed because they're really important to explain why data is shared, who's responsible for it and who can access it. And also, we need to make sure that those checks and reviews are in place so that we know what we've got and how many. And then teams should design their everyday workflows that match what their systems can actually do, avoiding double entry and using shared templates or quick summaries where needed. And when some information can't be seen across systems, partners need to agree a safe short-term workaround so nothing important is missed. But all documents and agreements should be stored in one shared place so that everybody can find them easily. So mapping your current data flows, it means identifying all data sources across primary care, community, mental health, social care, public health, voluntary and community sectors. But start simple. This is an example of a sort of table that you could use. But I wondered if anybody started this. Does anybody find this a challenge? Document in here what is shared, with who, and for what purpose, so that everybody understands what visibility they need. So do they need full visibility, partial or restricted access to certain systems? And then some of the audit system interoperability needs to be looked at. So API connections, permission levels, gaps that risk safety or create manual work. So capture findings in a live shared record that partners can all update regularly. And to improve data sharing, neighbourhood teams not only need a clear picture of what information is used, but also how it moves between organisations. So this means listing all the data sources across GP practices, community services, and the rest. And then teams should record who can see what information, what is shared, and why it's shared, again, recognising that GDPR that we need to follow. It's also important to check how well the different computer systems connect, whether staff have the right access, and whether there are any gaps that cause delays or extra work. So this is where your DPIAs come in. So we need to make sure that everybody has the right access to the right thing. And all of this should be kept, again, in a shared, up-to-date document so everybody understands the current situation and can plan all the improvements together. Just a question for those who aren't in primary care. Have you been asked about your data? Would you feel comfortable in sharing the data? Do you already do it? And if you do, how? It'd be interesting to find out if you could pop some comments in the chat for us. But I'll move on to Rachel. Thank you.
Oh, I think it's me, isn't it, Rachel, first?
It is.
Thank you. Hi, everybody. And it's sort of as we build on from thinking about the how data is shared in a neighbourhood and how that data then starts to bring a kind of rich picture of the need and demand and the impact that that the services are having. It leads us on to this next section of the presentation, really, which is how we then use that data and how we understand the data to demonstrate the impact that neighbourhood working is having. So we spent a long time, and as Claire set out, looking at sort of all of the different components of neighbourhood working as they're presenting to us, and thinking about some of the challenges and opportunities. But a big part of how neighbourhood working will need to move forward is about its ability to demonstrate the types of impact that I think the government and those at the top of designing kind of NHS and other public services are hoping that it will have. So essentially, how the shift of effort and shared and collaborative working is going to have an impact on how health services and other public services are used. So in this next section, we're going to kind of look at how, when you're in your neighbourhoods and working and looking at different projects and ideas, how you start to think about how you can demonstrate and measure the impact that they're having. So essentially, we'd start with neighbourhoods, really, with that need to establish a clear and shared purpose. we're going to look at the different approaches to measuring that impact. Some of the impact will be the data that you hold at the local neighbourhood level, but some of that data is also the system level data, and how you can see how your neighbourhood and the services you're providing within it are operating and how they compare to other parts of the system. We talked when we were looking at the population health management work around using cohorting, so particularly at the outset of neighbourhood working, really, and when we know that the resources haven't yet shifted necessarily to support different ways of working, but actually with smaller groups of patients, populations where there may be greater need, the impact of to have the greater benefit, then that is something that we'll also look at. So start small, starting with that small group of the population and showing that impact that can then perhaps be scaled up. As we're thinking about the different groups involved, or the different team members involved, then actually having simple reporting frameworks around that will be really important, and implementing and then using that to implement rapid cycle learning. So this section is looking at different types of impact, and then how we enhance that visibility and build evaluation into daily work. And I've just been told as well my internet is cracking a bit. Is that the case? So
you seem to be back now.
Seem to be back now.
Yes.
Gosh, I'm so sorry. So just moving on to the next slide then, we said at the beginning of this that it's really important to define the priority outcomes for neighbourhood teams. So we said always about starting with those broad ambitions, but then using the information, using what's known about the populations to agree on two or three or four priority outcomes that you'd want to start with, and then look at how those outcomes are going to be meaningful to your local population, but also to the staff and the teams and those involved in providing them. So I think when we go back to when we were thinking about the methodology behind a lot of the neighbourhood working, it's about defining that goal at the outset, and that plays the same with thinking about the data and thinking about how you're going to show that going forward. We were thinking about some of the quantitative data indicators that you might start to look at, and how that might frame some of the decisions that you take about where you start. So there'd be those urgent care indicators. So you see how your population is consuming urgent care services. So perhaps how they're using 999 or pitching up at urgent care centres, and looking at some of the non-elective admission data. Then we were thinking about some of the proactive care metrics. So thinking about the patients that might do well for being involved in multidisciplinary teams, and those that perhaps might have polypharmacy, so lots of different medications, and starting with those groups of patients. You could then look at how patients are accessing services, and where services have got significant pressure. Things like DNAs, so appointments that are missed. That often is an indicator of perhaps how services are being set up that might not necessarily be meeting the need. You could look at those prevention and outreach type data indicators, so some of the public health type indicators that would be helpful, and also the social and wellbeing support type indicators. So starting with some of that data that helps to set the picture to move forward from. And then some of those, looking at then how you can track those, because I think the challenge of a lot of this work is going to be that sometimes the benefit is going to be much further down the line, and being able to demonstrate that the impact that you're having justifies the effort, and the different ways of working is quite difficult for at the outset. So trying to think about the things that could be tracked early and show that early positive impact will help to keep everybody at the table. And I think this is a theme that we've picked up throughout the conversation as well, has been about avoid waiting for perfection. perfection. There's never going to be quite the right kind of situation or the perfect data set or the perfect setup to kind of get things going. But actually sort of recognizing some of the frailties in the data or some of the challenges that you might have also being kind of part of the purpose for what you're doing, so that actually some of the improvements in the information that you have and then the kind of the confidence in the data that you're able to collate can also be a real positive impact from this. I think this is where I pass to Rachel, which might be good if my internet is still playing up.
Thanks, Alison. I wondered whether we could quickly, before I launch into to my bit, there's a couple of points that have been raised in the chat that might be particularly pertinent in relation to what you've been talking about, and that's about referencing a sort of template in plain English signed by everyone. There's some experience about practices and PCNs, even within PCNs, not actually sharing their own data, let alone as a collaborative within the neighbourhood, which is challenging for that particular setup. And we've also got there's a lack of contact for some of our attendees here, there's no contact being started with any outside agencies, and also the challenge, and this real challenge that we hear all the time, and maybe Kamal be able to help with this in the Q&A, is that there's the fact that our voluntary and community sector partners have a wealth of information, both qualitative and quantitative, but being able to share that, and for that being a one way, and also the resources required to do that is over and above what their funding envelope would normally provide. The financial structure of voluntary and community sector is very, very different from our NHS and local authorities. So those are some points. I didn't know whether Claire, Alice, you had any thoughts on that particularly.
We'll have a go at reading through them and seeing if we can answer some of them, but if not, we can pick some of them up in the QA at the end.
Thank you. Thank you. So, can everyone see just the slide? I'm not sharing anything. I'm looking after a sick child today, and there's busy beans and something else on my laptop that I'm promising that I won't give you a download of that. But so really, I mean, this is one of my real passions, is qualitative data and storytelling. Much of the data that we'll be collecting will potentially be long-term change, where we see public health data that informs us of reduced smoking, diabetes. Some of that will be for sometime in the future that we get to see the impact of what we're doing, but our qualitative data can really inform our expected direction of travel there. So what I was just really wanted to cover off in this section is, well, what do we mean by qualitative data? And that is still robust evidence, and it's the stories that we have through our staff feedback, through our partnerships providing their insights into impact. Whether we look at cultural change in the shift of healthy living, healthy eating, those sorts of things. And so there's some brilliant work being done by yourselves out there. I mean, examples of diabetes clinics and other sorts of clinics where actually it is our patients, our cohorts that are taking control of these meetings, sharing about how they deal with particular challenges and changes, and then how that gets out and is reflected in the community. So there's a great deal of work there to look at. But one of the important things is you don't have to look at the outset of providing massive change, data change that's going to impact the 10-year plan to the extent that we have a revised 9-year plan or something like that. what our suggestion is, as we said earlier on, is start small, develop your models, have a look at how that's working, speak to others, share information. Obviously we've got our national pilots, but we know that there's lots of work that you guys are doing anyway already. Nobody's waiting for the results of that before you start. So really looking at who your core cohort selections are, and that you can clearly define those around the data that you'll be able to evidence, so the before, the during and the after. And some of that, as I mentioned, some of the post data will be something that will be collected over a few years potentially to see that impact, but your qualitative stuff will potentially point the direction. And it's really important that as we develop our cohorts of patients, population, I know all sectors call our population something different necessarily, and how actively involved they are, really to help define what some of our qualitative data looks like. I was involved in a project in Barnet where we looked at the data, the insight into digital, and we really looked at the qualitative behaviours, assumptions, barriers, and how to actually shift that, because just nothing would change, however much you might put lots of digital tools in place, unless there's a shift in understanding around how that works, what the fears are, all of those things. So also looking at geographical cohorts, you might want to look at an area where you particularly have areas of population deprivation that impacts social determinants as well as health. And that's something that you might want to think about, as that's part of the partnership, is actually having a look. It's not just about health, people's housing, education. It will be good that we can start developing what those determinants and behaviours might look like that impact those other areas. Everything potentially has that ripple effect. And you can probably hear that I'm passionate about this, so I'll move on to the next slide even. And again, what we're suggesting here is everything you do is going to be valuable. Everything you do, whether it's not working quite as well as you'd hope by looking at some of the outcomes, that's fine. It's still working. You've still got some great models. You've tested, you've looked, measuring even the small changes, and using, scaling up your successes. Because if you've got a model, to some extent, the content could be very different across some of your data and your measurements, but your models, how the engagement works, what systems you've got that can draw out what, you can very much use those to scale up in other areas as you start developing your ambitions within your neighbourhood. So nothing is not valuable. And here we've just got some evidence of the types of impact that you might want to consider. Fewer crises around approaches to reduce patient crisis through emergencies, that are sort of 111,999. Improved patient experience. We're in primary care, that's a consistent measurement. And it's not just on links sent out to patients to find out, annually what did they think. There's better, well, not better, there's other ways that we can do this, and we can do this in partnership, because our patients are also the client groups of our partner agencies, voluntary community sector, community care, our housing, etc. Whether we see increased independence closer to home, all of that agenda is great. Workforce engagement, this is really, really important, I think. And we, when we look at this type of work and data, sometimes we can tend to forget that actually, what's the impact to our workforce? Are our staff feeling more confident? Do they feel better engaged? Have they got an appetite for development? Do they want to stay? Are they key? Do we have you know, they still have the challenges with the recruitment, and all those measurements can be in place, because we know where we are with some of these challenges. Some of them will be impacted by outside, you know, geographical, how you get to places and things like that. But again, we can build in tolerances when we look at this, and obviously faster decision making. Are our models being built? Are our governances in place? Are our sort of our operational procedures enabling us to move quickly? Hopefully I've gone on to the next one. So some examples here of strategies for making impact visible. That's to our population, to our leaders, to the commissioners, to our partner organisations. We're looking at this as neighbourhood is what it says on the tin. It is about all of the agencies within that geographical footprint. So how do we make that visible? Well, we build it into our daily work. It becomes iterative, it becomes second nature, that we are working in a particular approach. I'm not going to say new, because I know many of you already do this. And it's about sort of trying to put that into how your neighbourhood modelling looks. But as we start thinking about doing things differently or doing more of, and making sure that all of our projects, we start off with some very clear, successful approaches, because we've built that into our daily work. So we've got our dashboards, we've got the regular impact stories, and some of those will be feedback, some of those will actually be stories. They might be stuff, information that we collect on video clips, where people are happy to talk about their experience. You know, visits and walkarounds. It's really important that that we have that direct engagement from our decision makers, and that's really difficult, as I know, as you know, that, you know, the reduction in workforce in our NHS England and others. You know, I do remember the days when dental commissioning, the commissioners visited the dental practice at least once a year for all of the practices within their area. Same for primary care. That just doesn't happen. But we need to actually foster that direct engagement and visibility of the efforts that our teams and the success that they bring to the 10-year plan's ambition, and regularly update our residents, our population. We have that transparency and community involvement. Have a look at what doesn't work. I mean, I get a digital newsletter from my local authority, and I do look at it, I guess probably because I sort of work in that environment, and I know what sort of information is there. But when I ask any of my friends, you know, nobody recognises they got it, let alone read it. So I think it's, you know, are our communications right as well? So really, I just wanted to finish on the summary here, that we have that clear purpose, we have our practical metrics, we have qualitative insights, passion of mine again, as I'm saying, and just in case anyone didn't know, it's a real passion of mine, and ongoing learning and visibility. Let's showcase our success. Let's share what we've worked on, even if it hasn't given you quite the outcome you were looking for. The fact that you've done what you've done, and you've engaged, and you've looked at modelling, you know, all of those are success stories, and we're in very early days of our neighbourhood team. So please don't feel that the things that you do in, you know, you've got to get it as some big shift change in the NHS 10-year plan. It is about starting this process, getting familiar, getting engaged. So, you know, that's the end of my session.
Thanks very much, Rachel. Okay, so we're going to move on to just looking at a couple of stories from people that have attended these webinars, and some other things that we've been looking at. So this first one is from Kath McLennan. You may have seen her. She's quite prolific. She is an NHS app ambassador, and she does all sorts for Bay Medical Group. But she's recently joined one of their local community groups on their INT to promote and encourage all things digital for their citizens. So it says there what she does. She goes to that drop-in session and she absolutely loves it. So I thought that was worth sharing. That's a real positive story, and just a different way of looking at things, because that INT is obviously focusing on upskilling, digital skills of their community. So that's another thing that you might decide as a cohort to go with. And this is from Lisa Jones. So she's on LinkedIn, but was happy for me to share her information on here. So this is a post that she popped on. But as you can see, I am not going to read it all. You can have a look afterwards when you get this slide pack. But she does mention many of the points that we've discussed. So creating a clear mission, outcomes and accountability, that testing, learning and growing, the development of the voluntary, community, faith and social sectors in those relationships. And again, that using the multi-agency approach. She also mentions ensuring that we know the what, the the how and the why of data, and using that strategic and investment agnostic approach. And then again, at the end there, the better communication, using those regular check-ins of joint commitments. So it's really useful to have these people on LinkedIn. There are loads of people sharing their stories through neighbourhoods and what they're doing. You can find Lisa on LinkedIn. She's a regular poster, but you might find it useful to follow her and to follow other similar people in roles just to get some ideas and to read about some of their successful outcomes. So over to you. And I did send out an email warning you that I was going to ask if anybody would like to share any of their progress, even if it's just something really small, like we've contacted our voluntary faith sector and we've started a relationship. There's lots going on. I think your microphones and cameras have been enabled now. So if you'd like to share any of your progress up to date, please feel free. If you don't feel comfortable in sharing right now, that's absolutely fine as well. You may just have some questions that you want to pick up with us in the Q&A section afterwards. I know that Rachel and Alice have worked with a couple of INTs recently. I don't know if you've got any progress stories.
Oh, my mic's on. I thought I'd switched it off. Sorry. Yes. I mean, yes, we are working with a number of clients at early stages of this. A couple where we're utilising the CQC readiness service that we have to work with a number of practices to utilise the particular areas that underpin neighbourhood working around governance and infrastructure and looking at the data. We're not data people, we're not like Claire and her team in that sense, and have had quite a few data sharing agreements we've been asked to have a look at, because again there's so many, but also it's the understanding. And I think that also was noted in the chat here, that I think one of our colleagues in attendance has suggested that they've moved from the IT areas and into the primary care area, and there really is a shortage there. And you know, I think is there a need here? Is there a desire? And should we be looking collectively about how that things like data sharing agreements, looking at the contract requirements, because we're also seeing many of our contract providers, and I'm not going to, this isn't a name particularly, but I know that the Joyous system has expanded what it offers, and in order, you know, commercially companies will want to do that to meet neighbourhood ambitions, but how that comes with new agreements, new clinical oversight, you know, and I know that can be confusing. I think there's a lack of space at the moment for those areas. I don't know whether anyone else is finding that. A nod, a shout. No. Okay. Yeah.
It's fine.
Well,
We'll
we've got an
move on.
absolutely. Thanks, Sharon.
That's great.
And another area is particularly looking at children and young people in through the social prescribing route. There's a real opportunity to look at, rather than direct funding, as in, we're going to need more money, because we know that there isn't, as to how we can work collectively. And one of the key areas, and a couple of projects that we've been working on, is having a look at where children and young people's early intervention can be collectively workforce modelled, shall we say. So we've got children and young people social prescribing in some of our PCNs. We've got equivalent of social prescribers, but they're not called that, sitting in some of our local authorities. We've also got some of our community and voluntary sector focusing on children's and young people's mental health and early intervention. And there is some overlap and there's some gaps as well. So, it's looking at pulling those together as a workforce. And that's, again, sorry, I have many passions, but children and young people's mental health is particular. And that has a real impact on our waiting list for acute mental health and community mental health. We know that the waiting lists are huge, and there's often a potential 12-month plus wait in many areas, whereas that early intervention, it really hits home about the difference that can make to our, and then working with schools as well. And we know that the ambition is for a mental health person to be in the schools by, I think, is it 2026, 27?
Nisha, would you like to share?
Yeah, I was just going to come in. I was started typing it, and then I thought it's just easier to say it. So we've started doing a piece of work addressing health inequalities in our area, and it's very similar to what has just been said. So we're working with the VCSEs in the area. We are fact finding and running some focus groups with young people, carers and the schools to understand what the challenges are, because in Leicester City we have got MHPs working in the schools already, but actually the demand for the service is so great that we've also got an MHP that's fully booked in our area, constantly supporting those people that need that help. But we're now trying to see whether we can start up at supporting things like the sexual health clinic, awareness on managing carer commitments, those sorts of things. So it's a work in progress, but there's lots of governance challenges that we're working on to try and target, like getting information out. The police, because obviously the community police support are supporting young people out on the streets, the VCSEs and their governance structure with data sharing agreements and what sort of data they're holding. The intel they have is really, really valuable, but it's all qualitative. But how do we then share what we're doing back with them? And I think the biggest challenge we are currently facing is that we want to be out in the community as primary care, as GPs, but actually there's certain limitations on our insurance, that side of things, that are causing problems too. So there's those things that we're working on, but I just thought I'd share.
Thank you very much, Nisha. That's amazing. That's lovely to hear. I know we've got in here, Christine's popped, we're in an area and have a social prescribing holistic model and have had for over 14 years. So we knew that people were already doing this. It is just scaling it up, isn't it? And this approach works equally well with children and young people. So that's another fantastic story. So I'm just going to move to the next couple of slides and then we'll come to Q&A. I'm giving you some supporting tools. So we have spoken about these tools throughout these webinars. And if you haven't already, it's worth having a look at some of these resources to help guide you. So we've got the D&T Network. Obviously, we've spoken about that. That is a place for you to connect with others about neighbourhoods. We now have that new voluntary and community section in there to expand our conversations around neighbourhoods. And all of the resources from today's session and other sessions are on there for you to have a look at. There is the D&T Hub Readiness Assessment, and I know a number of you filled it out when we shared it after the first session, and there was sort of middling to sort of mature answers in there. So it's looking good for being ready to get this going. We've also got the CQC readiness tool from At Scale. So that is available for you to use from these links here. And also the leadership assessment. So I think we shared that on the last session, just to look at how you're ready to lead these teams and who does what. There is also another bid readiness tool from At Scale that you can have a look through and see if you can find out any more information there. There is a new workspace on futures for neighbourhoods. So the link is there. It's up and running. It's well worth having a look to see what they are sharing at the moment. And just an interesting article for you. So Digital Health looked at how local digital maturity will shape the neighbourhood health service. So it's a really good article that you may want to read. And also LinkedIn. So as I mentioned before, lots of these stories, I'm seeing loads of stories about neighbourhoods on LinkedIn, and whether it's because it's picked up my algorithm that I'm interested in them and it's flagging them to me, it could be that, but absolutely loads of people are doing this already and are posting their progress and their stories on LinkedIn. So it's a really fantastic place for you to have a look at. The other support available for you is obviously Redmoor and At Scale. We're running these webinars, but we recognise that, you know, neighbourhood working is moving quickly across the country, and it's completely normal to feel that some areas are already further ahead than you are. But every neighbourhood starts from a different place with different pressures, relationships, levels of maturity. So we're offering out a free discovery call. And it's a safe, practical space to talk through the challenges that you're facing right now. Maybe start to unpick what's blocking progress, whether that's relationships, data, governance, capacity, or that direction. To understand what good look likes and how others are approaching similar issues, and explore early opportunities that you can focus on straight away. And we can also see how some of the emerging digital products link to the work that you're already doing. You may want to use some of them. So if you're feeling stuck, stretched, or you're not sure where to begin, we're here to help you move forward. So you can book in your free discovery call by emailing our support address, which is on the screen there, and we'll also pop that in the chat for you. So moving on, we've now got the Q&A section. So joined again, thank you very much by Kamal Bayer. If you have any questions, I know we've got some questions in the chat that haven't been answered. Let me just have a whiz through. So there is lots of chatter, Kamal, about the challenges that people are facing with data sharing, DPIAs, DTACs, risk management. What would your advice be on looking at that, getting more information on that and going forwards?
Shall I take this on a couple of fronts? If I take it with my old practice manager hat on, so we used to have problems when we were trying to link in with our community matrons and district nurses and social services colleagues. And we were trying to have one source of the truth, so that if we had a care plan for a patient and we were all collectively involved in the care of that individual, that we knew what the latest situation was. And this was before the day and age that, you know, we had all these APIs and abilities to share across different things. And basically, I mean, we had to find workarounds to try and make sure that we were connecting and sharing. So when I hear what colleagues are doing now, I think it hasn't changed that much from when I was saying, oh, I'll make you a user on my EMIS and you can have a shared view of the record. So I think there's a lot around data sharing, and I was hoping that the new federated data platform, which is looking at the future of a single care record and the whole data sharing issue, was going to resolve it. But unfortunately, they didn't tackle primary care in the first instance. So we have been shouting about that and saying, can we have some connectivity? But the other pressure that we keep trying to put upwards is the fact that if we've got clinical suppliers who are providing systems, we need them to be thinking forward and have the ability to provide the capability that we need out of future platforms as well. So on lots of fronts, frustrating, I know, and I can't give you a quick fix because it depends on what's happening in your area. But I would say connect into your local digital teams to find out what's happening. There will be people who are able to help support. I think the data sharing is the first one. If you can get that across an area and make sure that you've got agreement to share different levels of information, I think that absolutely is the best way forward. That then provides some reassurance for the data controllers when they're trying to release it. So
thank you. It's hard to unpick, but like you say, unless you know the specific area and what you're dealing with, but that's brilliant. I've got a question here for anybody. So please, could anybody with social prescribers provide me with some examples of what they're doing outside the typical role? So this is from Justine. We have 3 social prescribers in our PCN, and for the first time in many years, their caseload is low. So we're trying to look at alternatives as what they can be doing. Okay, Sarah's just popped an answer. I wonder if there's anybody that would like to come on and give some ideas on what they're doing with their social prescribers, whether Sarah would like to come on. Or maybe not. Okay, we're getting some ideas in the chat. Okay,
I'm here if you want me to say something.
Yes, absolutely.
Hi.
Fabulous.
Hi. Ours have quite a community focus, so we've got 3 who are more sort of social prescriber health coaches, and they sort of have a hybrid role, and we give them 1 session a week to be out in community engagement, getting into local, church-run groups, coffee mornings, all that sort of thing. And the more relationships are built with the teams running those existing groups, the more they're able to contribute to conversation. And occasionally we've had health and wellbeing talks run by our social prescribers and health coaches attending those. So it takes time to build those relationships, but definitely worth doing out in community rather than people coming through your doors if they're based at the practice. So that's been helping us quite a lot, alongside food banks and that sort of thing. Lots going on there.
Fab. Thank you very much for sharing. Thank you. I can see Maria's also shared as well. They're delivering a social prescriber project, a proactive social prescriber project. I wonder if you wanted to come on, Maria, and give a little bit more about that.
Hello.
Hi.
I think this is a national ask, or at least a local ask from our ICB to deliver what we call Tier 2 high impact use proactive support. So we're doing searches and trying to find certain cohorts of patients with certain health conditions, plus a high attendance of A&E or GPs, and we're trying to have conversations about what matters to them and putting some support around them that would hopefully improve their well-being and reduce the number of contacts with medical services. So that's one thing that we've been delivering for a while locally, but we also have, like I said, we have a very successful dementia gymnastics program that also supports and offers peer support to the carers while the dementia patients do gymnastics. We are my PCN is piloting aligning neighborhood teams with city council, county council, mental health teams in the volunteer sector, with the hopes that we'll be having named people across different sectors of who's supporting the same residents, and that we'll be able to align our mission and how we're meeting our the residents' needs and putting together some events. Yeah. And yeah,
Fabulous.
we're also planning a pain management service using a coaching approach.
Yeah, amazing. Thank you. Rachel, you've got your hand up.
Sorry, I also wanted to add to the brilliant work that the social prescribing teams and care coordinators who often work with them do, is that they have very strong established links with other providers within the community, with what we will be now calling neighbourhoods, and so, and it's really useful to start drawing on those, almost the lists that our social prescribers have of our community groups and our community partners, because they have already trusted relationships there. Now, as we draw into developing our neighbourhood models, where everyone has a space at that table, we can draw on those relationships to help develop into our modelling, and I think that's really useful. Let's not forget we've got a workforce within our PCNs that already have those strong relationships, so we don't have to start going out and finding them. Finding them is probably the wrong word, I do apologise. And hopefully many of our community voluntary and faith sector groups through that already have an idea of how PCNs are working and modelling, but also looking at some of these examples. They are great examples of what your pilots for your neighbourhood health could look like, because you're already doing some of this at that level with your partners. You can very swiftly look at how you utilize those measurements and those relationships and those models of service to your neighbourhood health. There's some great stuff in here.
Yeah, thank you, Rachel. And Kamal, just as a last point, this is the last in the 3-part series, and this has been like a Foundations to Readiness series for integrated neighbourhood teams or neighbourhoods. What would your top tip be for people who are in this position? So they've either got ideas or just started. What would your sort of top tips be as to where to go next, what to do?
I think have conversations and talk to people, because if you're passionate about something and you want to drive it, sometimes you're thinking, I can't do this on my own, or I need to, and you shouldn't be. Just connect with people who are already interested in what's going on, working locally, working in that environment, and you'll soon find that you build your group organically, if you like, just from having those conversations. And don't be afraid to test it. We're not expecting everything to be fantastically working from day one. This is a journey and we're all on it together, so keep testing, keep trying, adapt things, and make sure you're measuring, because you need to see if you've made a difference, whether that's to staff experience, the person who you're working with, or whatever, really.
Thank you very much. Thank you. So just a couple more slides. So again, we're going to ask if you have some time, please could you fill out our feedback form for our session today. As we said, there is a chance you go in a monthly draw to win a £25 Amazon gift voucher, so just in time for Christmas. That would be lovely. But we really do appreciate your feedback, just to know that we are hitting the right points, giving you the right information and setting things out in a way that you can easily understand them. So that would be fantastic if you could provide us some feedback. I will pop the link in the chat as well in a moment. But just to say, thank you very much for joining us. Thank you very much to Rachel, to Alice, to Kamal, and thank you very much. I hope you found this useful.